Welcome, everyone, and thank you for joining us today. Heart and Stroke is pleased to host this webinar in collaboration with HeartLife Foundation. This week is Heart Failure Awareness Week, led nationally by the Canadian Heart Failure Society in collaboration with partners across the country. Bridging heart failure care is essential as heart failure remains one of the fastest growing cardiovascular conditions affecting more than 800,000 Canadians. Heart Failure Awareness Week plays a critical role in strengthening understanding of this complex condition by highlighting the importance of early diagnosis, evidence-based care, and seamless connections across the care continuum to better support people living with heart failure, their caregivers, and also clinicians. My name is Shannon Doucette and the Heart and Stroke Foundation Heart Project Lead, and I'm pleased to be moderating today alongside Mark Baines, co-founder of the Heart Life Foundation. Mark and I will guide you through today's session and will also facilitate the question and answer session at the end of the webinar. When you join today's webinar, you will be joined through a computer audio. If you prefer to listen with your phone, simply select phone call or select call me and follow the prompts for more options. Questions are welcomed during today's webinar, so please feel free to enter them through the question panel and they will be addressed during the Q&A period at the end of the webinar. And lastly, today's webinar is being recorded and will be shared afterward on the Heart and Stroke and HeartLife websites listed. Today, we would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call these lands home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We encourage you to reflect on what that means for you in your work and also in your lives. With this grounding, let's review the objectives for today's webinar. We'll start by recognizing early and advanced signs and symptoms of heart failure. We'll discuss risk factors, including what can and cannot be modified. We'll explore how heart failure connects with other conditions. We'll review the role of guideline-directed medical therapy and why it matters so much. And most importantly, we'll reflect on what it means to center care around the persons with lived experience. Now, I'll pass it over to Mark to introduce our speakers.
Thank you so much, Shannon. Appreciate this and appreciate the partnership with Heart and Stroke and Heart Life. We are running a few years into these webinars, and year over year, we are getting some amazing speakers, like you'll hear later today, some fantastic topics that are important for people in Canada and across North America and the globe, and more participants as we continue to push this forward. So I think we're becoming, a go-to for a year. People look forward to this. We might have to look at maybe biannual webinars. We have over 500 people right now on this webinar, which is exceptional. So to all of you on the call who joined, who registered, who want to learn, thank you so much for being here. We are so grateful to have you. I get the great fortune to introduce some amazing speakers that you're going to hear from. First is a friend of mine who I didn't meet too long ago, actually, just maybe about a less than a year, Joel Buena Cruz, who is a patient partner, a personal lived experience, heart and kidney transplant recipient, and really just an inspiration. When I met Joel, he was full of life, full of energy, and continues to be that. We're looking forward to hearing his story. Dr. Daniel Nui, who actually is a family practitioner, clinical professor, University of British Columbia. He's a medical director of Fraser Street Medical Clinic in Vancouver. Funny enough, his clinic was about 5 minutes from my house where I grew up, right across the street from my high school. And the first time we met was overseas in Amsterdam, of all places. Daniel is just a wealth of knowledge, a great human being. So happy to have him. And Dr. Morgan Crowder, who I just saw last week in Montreal at Heart Failure Update. Morgan is a doctor of nursing, nurse practitioner lead, heart function program at Royal Victoria Regional Health Centre in Barrie, Ontario. I mean, just a salt of the earth human being. We had a chance to chat at Heart Failure Update and looking forward to what she's going to say and bring to the table. Thank you all for agreeing to do this. Looking forward to the presentations. Just going to switch to the next slide to show the conflict of interest real quick. Here they are. Take a second to take a look at these conflicts of interest. And if you're not on this board as a industry partner, reach out to these people and you should be working with them. And next slide, please. All right, Joel, I'm going to hand it over to you. You're looking great. Looking forward to hearing your story.
Thank you, Mark. So my name is Joel Buena-Cruz. I'm 57 years old. I live in Maple Ridge, BC, about 45 minutes east of Vancouver. As Mark said, I have survived a stroke, an LVAD, heart and kidney transplant, and Gen X, and I'm also a type 2 diabetic. Next. My journey through misdiagnosis and bad choices, well, there was really only one misdiagnosis. The rest was my bad choices. I was born in the Philippines, 6 weeks premature and under 4 pounds. 3 hours after I was born, we were hit with one of the biggest earthquakes in Philippine history. The hospital was sent into a state of emergency and my care became secondary. I was considered a miracle baby, not because of the earthquake, but because I was conceived 3 years after mom had a bad miscarriage and was told she'd never conceive again. I'll always be forever known as the earthquake baby with my family back in the Philippines. First sign anything was unusual was that I would not wake to be fed. The parents had to wake me up and force me to eat. They didn't investigate it because I was a miracle child. And 4 decades later, we discovered that I was likely born with a faulty heart valve that led to my future heart and kidney issues. I'm the youngest of 4 natural children, and we adopted 2 younger siblings after me, 2 shy of my parents' ideal 8. Next slide. I came to Canada when I was 1.5 years old. I had a very normal life. I was very athletic. I played all kinds of sports. I loved combat sports, team sports. I was a gym rat, outdoorsman, and whatever I could do to challenge myself. At 13 years old, I had the second sign of very unusual health issues. I was diagnosed with gout and high blood pressure. My doctor at the time deduced that it was probably from the heavy North American diet that I was not genetically used to and just treated me for gout and high blood pressure. At 15 years old, the third sign that something was wrong is that I would black out during sports. I would black out, drop to one knee, and stand up immediately. And only one teammate ever caught me, and I did not report it to my doctor. But like all Gen X cool kids, I smoked and I drank and I took casual drugs. And from my teens throughout my 20s, I maintained that lifestyle of high activity and bad habits. I always rewarded myself with smoking. I would go run, have a smoke, climb a mountain, have a smoke, play tennis with cigarettes hanging out of my mouth. And I always just thought that if I could do all this stuff, how bad could smoking be for me? I ignored the fact that my blood pressure kept going up and that my gout attacks were 2 to 3 a year. At 30 years old, the fourth sign that something was wrong happened. I suffered a TIA, or mini stroke. I was really angry and antagonistic at the hospital staff, and they had to place a balloon through my sinus cavity and inflate it to put pressure against my brain, I assume, to stop the bleeding. And I was so mad that I actually checked myself out, AMA, and went home, took the balloon out, and went to work the next day. Next slide. I'm 34 years old. I had the fifth sign that things weren't okay when I was diagnosed with hypertrophic cardiomyopathy and impaired kidney function. I had all the symptoms. My muscles ached. I couldn't breathe. I was put on a whole slew of medication and told that I probably wouldn't live the next 5 years. And for 4 years, I was in and out of depression, mostly in depression, and life just felt hopeless. After 4 years, I decided that if I was only going to live 1 more year, I wanted to live doing something that I loved, and I wanted to take martial arts again. And somehow I found an instructor that was willing to take me on with all my medical issues. Every day after class, I'd go home and I'd feel terrible. I honestly thought I would die each night, and I'd look in the mirror and say, if I wake up tomorrow, I will go back. And I kept waking up and I kept going back, and I slowly got stronger and stronger. And sure enough, after a year, I was training at almost 100% again, and I was preparing for competition. Unfortunately, as I felt better and better, I fell into all the same bad habits. And for the next 17 years, I went through a lot of major health ups and downs. I had heart attacks, many stents, ICDs, and a whole bunch of hospital stays. But whenever I was up, I'd always recover back to almost 100%. And I'd be climbing mountains and do mass training sessions, and I'd run around telling everybody that I heal. I always heal. Rock bottom, yeah, that was my bad choices. I had developed a severe case of pneumonia in September 2023. I was in the hospital for about a month. I was put on high oxygen ventilators, heated air, and put on a very heavy antibiotic and steroid program, which I continued for 2.5 months after hospital. I finally accepted that I do not always heal, and I quit all my bad habits. But unfortunately, the next 7 months had me in the hospital more than home. I had recurring pneumonia and caught COVID. I had multiple ICU stays. I'd been in a coma and many periods of delirium and vivid hallucinations. By June 2024, my heart and kidneys had all they could take. I'd lost over 40 pounds, and every day all I knew was fear. I didn't know if I was ever going to make it. I knew my family was afraid. I was exhausted, and I honestly wanted to give up. I was told that I needed a heart transplant, but I probably wouldn't survive a heart transplant unless I had the LVAD procedure. We all knew that I needed it, but honestly, I was so spent that I did not know if I wanted to go through with it. The transplant team put me in touch with an LVAD recipient who later became a very good friend of mine. He was telling me his story, and it was very close to mine, all the same fears, all the same anxieties. But he was laughing and joking, and it wasn't really the story that got me. It was the fact that he didn't sound afraid anymore. And I wanted to feel that too. I didn't want to be afraid anymore. So I consented to the LVAD, and in July 11th, 2024, I got it. Next. The LVAD was not great. The first week was hell. I woke up in pain, confusion, having vivid hallucinations, and had to have an emergency chest tube put in because of fluid in my lungs. Having that then when you're awake really sucks. After the first week, though, it did get better. And before long, in under 3 weeks, I was heading home. The LVAD journey was full of ups and downs, where the ups were actually more like mids. The machine keeps you operating at a very moderate level. You can't push, but at the same time, you can't really go down either. The downs involve PTSD, many sessions of PTSD, reactions to meds, and unfortunately, a infection with the equipment that lasted throughout. But for the first time in a long time, I did not feel afraid. I was never back in the ER for any of the downs. But the LVAD did give me time to settle affairs, to reestablish relationships with my siblings, and to cherish the time I had with my wife and children. It also gave me the time to train for the transplant. I was initially cleared for transplant at 3 months and I chose to hold off until I felt strong enough. And at 8 months, I put myself on the list. I also told the cardiologists and nurses that I would stand on the first day after surgery. And I'd be home before my birthday. Nobody really believed me. I don't even know if I believed me. July 11th, 2025, I got the call exactly 1 year after the LVAD. And I was really excited, and all I could think is I trained for this. July 12th, 2025, I went in for the double heart and kidney transplant. One of the fellows I got to know came to wish me the best and asked me how I was feeling. I instantly said, I trained for this. I'm going to stand as soon as I wake up. And when I was being rolled into the OR, I just kept repeating to myself my name, where I was, why I was there, the date, all the cognitive questions they could ask me, and that I would stand. And when I woke up, everything felt right. It didn't feel like there was anything out of place inside my body. I answered all the cognitive questions immediately. And I said, I want to stand up. It took a little convincing, but the nurses did help me stand, and I smiled, that same smile you see in the picture. And my recovery after that remained completely atypical. By day 2, I would stand assisted and try to use the commode, but nothing really worked. I was just paranoid. I didn't want to make a mess. And I was moved into a special ICU room to be moved up to the cardiac unit. Day 3, I was able to do an unassisted stand and assisted walk. Day 4, they moved me to the unit, and I was assessed and allowed unassisted walks. Day 5 and 6, I was doing squats in my room and practicing stairs. And by day 7, I was able to walk up 4 stories of stairs. At this point, one of the cardiologists wanted me to go home to continue my recovery, but heart and kidney transplant had not even started my training yet. By day 11, I finished training and was discharged, but opted to stay an extra day because my first post-transplant appointment was the next morning at 7 a.m. And by day 12, I went home. I went home to this wonderful gift from my kids. They spent all day yesterday, the day before, doing that for me. It was one of the happiest days of my life, July 24th, 2025. My recovery was amazing after that. By my birthday, 8 days after I got home, I was walking 10,000 steps, and a week after that, 20,000 steps. At 2 to 2.5 months, I was paddleboarding, hiking, and I climbed to a lookout point, which was the first picture of my slide presentation, at Golden Ears Park, and went on a 35-kilometer bike ride from Burnaby to Vancouver around the Stanley Park seawall and back. Next. Merry Christmas. By Christmas 2025, just over 5.5 months after post-op, I completed my year-end fitness goals, which was 20 push-ups and 30 crunches in 1 hour in the stand-up elliptical. It didn't sound like much, but when your sternum is being cut open and your abdominal muscles cut open, it felt like quite the achievement. The transplant recovery wasn't all great. I did have a lot of reactions to meds. There's a kidney infection that still bugs me to this day. It could cause a rejection of the kidney, but it's being kept under control. And I do have issues with bouts of dehydration. But the ups are so amazingly high that the downs seem like more like inconveniences than anything. I'll forever be grateful to the amazing care the St. Paul's teams gave me, the love and support of my family and friends, and the amazing gift my donor and their family gave me and my family. My continued motivation comes from myself and my family and wanting to make the St. Paul's crew proud. And I will always dedicate my continued recovery to those who unfortunately couldn't complete their own journeys. I kind of want to end this with a story. I was having lunch with my daughter the other day, and we were joking about how well my recovery was going. Oops, sorry, there's a cat here. And she was making a comment about how she should have beat me up when she had a chance, but now I'd whoop her. And she made a comment that I seemed to be growing younger. And I just laughed and I said, it's because I love life now, baby girl. And as soon as I said it, we both instantly realized that for probably the first time in my life, I actually meant it. And that's it.
Wow, Joel, I don't know what else to say, but wow, what a story. I mean, it goes to show the challenges and the road. It's not a straight line when living with heart disease, but definitely not a straight line when living with connected conditions. I mean, there's mountains to climb, and you climbed them. You not only climbed them, you made it to the top in record fashion. Unbelievable. You continue to be an inspiration to so many people and all these people on the call. Thank you so much for
Thanks, Mark.
sharing your story, for punching through that adversity, and really, I mean, understanding and sharing the power of hope and what that can do for people living with chronic conditions. Thank you so much for that. It is my now honor to introduce Dr. Daniel Nui, who's going to talk about recognizing signs and symptoms, addressing risk factors, and managing connected conditions. Daniel, I'll hand it over to you.
Thank you so much, Mark. And first of all, welcome to the 629 participants. And we're all here today to honor Heart Failure Awareness Week and express my gratitude to Mark from Heart Life and Nurse Shannon from Heart and Stroke Foundation. Joel, you've taught me the patient perspective, and I want to thank you for that emotional, inspiring, and impactful session. And Dr. Crowder, the nurse practitioner, the specialist perspective, I'm really grateful for what you've taught me about how specialists play a huge role. I've been a family doctor for the last 25 years, and I wanted to say that I wanted to share with you, with patients and with partners, what's the most important thing when you're working with a primary care clinician. So first of all, in primary care, we're the first point of contact. And so we really need to listen to our patients and partner to detect and prevent heart failure early on. Also in primary care, we're beginning to now understand the interconnectedness of multiple conditions. Something we call the cardio kidney metabolic syndrome. The heart, kidney, and our metabolism are linked. And so we need to treat the whole patient. And so you should be asking your providers. Finally, in primary care, the call to action for both our patients and our providers that we work with is to think about striving for proven preventative, uh, protective medications, guideline-directed medical therapies, and we need to apply them proactively earlier on to prevent heart failure in itself and the complications. Next slide. So what this slide shows is that primary care will see a lot of patients living with heart failure. So in a Spanish study, the prevalence can range from 3% early on, and as people age, up to 15%. So for each primary care clinician, we could have anywhere from 50 to 75 patients that are living with heart failure. And over our lifetime, 1 in 4 patients can develop heart failure. So patients, we need you to be on the lookout, partner with your clinicians. Clinicians, we need to start looking out for this as there are an increasing number of patients dealing with different types of heart failure. The problem with heart failure, it's hard to diagnose initially because it's gradual, non-specific symptoms that can lead to some confusion initially on. But the bottom line message is we need collaboration between patients, primary care, and specialty practices, cardiologists, so that we can kind of do a better job. Next slide. What this slide shows is a general kind of description. What do you need to know as a patient? First of all, it's a chronic progressive condition, and we heard that from Joel. The muscle pump can't work efficiently enough, or it's so stiff that we can't meet the body's needs. And so this leads to a whole bunch of things such as symptoms of extreme fatigue, shortness of breath, congestion, which can show up as weight gain or swollen ankles, as well as there are different types of heart failure that we need to know about. The other thing that we need to also be aware is that later on you'll see that heart attacks, high blood pressure, smoking, diabetes, valve disease can lead to heart failure. And the reason why we all must strive to work really hard is that the prognosis is serious. It's serious but manageable. And we need to focus on quality of life. We need to focus on self-care and getting our patients on the right therapies. This condition requires a lifetime of care. We need patient involvement. We need partnerships with all the clinicians. Next slide. So what I'd like to share with everyone listening is that we need to focus on the glass that is half full. We need to focus on the positive things that we can modify. On the left-hand side, you'll see that if we can control blood pressure, if we can keep diabetes at bay, if we can reduce obesity, encourage physical activity, stop alcohol and reduce alcohol and smoking usage, if we can really focus on identifying things like poor eating habits or sleep apnea, these are the modifiable things we can do. Let's not worry about the non-modifiable risk factors, except to know that if you have a family history or if you've had a heart attack or if you had a congenital condition, you need to think about this front and center with your clinician. Next slide. This is an important message for all of those listening in who are patients, because if you have these symptoms or signs, you may be dealing with heart failure, so you should speak to your clinician. If you're short of breath at any time, if you're noticing swelling in your legs, in your feet, in your ankle, in your abdomen, the reason why everyone should have a scale at home is that daily weights can help identify rapid weight gain. And especially if you're noticing a change in fatigue, a skipping heartbeat, if you notice that you're not thinking smoothly or confused, you're having difficulty concentrating, or if you're having GI symptoms like you're having nausea, or if you're coughing a lot, these are all the potential signs and symptoms of heart failure. They're different for everyone, and they don't always appear all at once. So you need to track these changes and contact your care team early. That's my message to you as a primary care clinician for patients living with any heart condition that can lead to heart failure. Next slide. So it's very important that if you do have heart disease, you get education because we need you as part of the team. And the reason why I mention these danger signs is that we often have heart failure action plans. Oftentimes, your clinician will give you a written guide what to do when you have symptoms. And you're part of the treatment. You need to learn how you can be an active participant. And so, in between visits, where do you go? Heart Life, Heart and Stroke Foundation, trusted organizations who will have resources and support you when you're not with your clinician. And really, we all want to empower you as patients. Clinicians want patients to be confident. We want them to be self-managers, and we want to always work with organization. And so focus on finding your trusted health organization that can provide you with information. Next slide. What this slide shows is in the three circles, we need to start thinking about interconnected conditions. I mentioned the heart, the kidney, and your metabolism. They call this in medicine the CKM spectrum or syndrome, cardio kidney metabolic syndrome. And so, what often happens is that we have these conditions that rarely occur in isolation. When you have one problem, it affects the other. When you have all three problems, it can be a big challenge. And so we need a holistic approach. And what really matters in primary care is that we see patients for decades. For the last 25 years, I've just been reminiscing about people I met the first day of my career and saw them last week. In primary care and with patients, this is a marathon, it's not a sprint. But remember these interconnected conditions. During these regular visits with your primary care team, you can help be part of the solution, finding out the cardio kidney metabolic syndrome. Next slide. So I think it's very, challenging for patients. Patients can feel discouraged. It can be daunting, but it's okay. And the reason why is that all of this is on a continuum, and we can't just do it in one visit. The message I have here for you is that continuity of care is very important. We need to do it together, and we need to be on medications that affect all these three organs. And perhaps a good way of thinking about it is that having a visit with your doctor should be a joy and not a chore. So your doctor should probably be funny or really engage with you. And you need to think about, hey, this is my chance to share with my clinician. Multiple visits are not a burden. This is how we keep you safe. Next slide. The last few slides will talk about the patients in the center, where the family, caregivers are surrounding them, and finally the team. Next slide. I'd also like to say that in a primary care team, we often have family nurse practitioners, as well as primary care nurses, as well as clinical pharmacists that work in your local team. And it's very important that they all overlap to make sure that we're not missing any patients. Next slide. Alongside your primary care team will be your heart failure care team. And you'll have a heart function cardiologist, perhaps a heart function nurse practitioner like Dr. Crowder. You'll have dietitians and social workers. So you, as a patient living with heart disease, need to embrace your whole team. We all have roles to play. Next slide. So, as a patient, what do we want to hear from you? We want to know what your priorities are. We want to know your values. And so, the next slide that I'd like you to move to will ask some key questions. Maybe you should jot this down. Ask yourself, what's your priority right now? What are your goals in life? What worries you most? And what barriers are you facing? Bring all of these questions to your clinicians. Your values and priorities are not afterthoughts. They need to be the compass that guides every care decision that we make together. That's my message. Then we'd love to hear this from you as a primary care clinician. Next slide. The last few slides will focus on improving outcomes with different medicines. And next slide. I think that a simple way to think about this is that we need to give you disease modifying therapies. And the next slide I'd like you to move to would be that there are personalized best therapies. Now, all you need to remember is that there's four different medications that can help you. There are classes like ACE and ARNIs, beta blockers, incretins or GLP-1s or GIP, GLP-1s. There's MRAs and non-steroidal MRAs and SGLT2s. Suffice to say that you don't need to memorize this. You just need to know that being on these therapies reduce hospitalizations, improves your survival, and can enhance your quality of life. Ask your team, are you on the right therapies? Have you individualized my care? So if we go to the next final few slides, when you have a type of heart failure which is called reduced ejection fraction heart failure, these are the proven therapies that you should be asking for, that your clinician should be striving for, because they all have a role to reduce complications. And these are what we call the pillars of care. And so suffice to say that as a patient, you need to trust that your clinician is striving towards guideline-directed pillars of care. These are the classes of agents. So don't memorize this, but simply ask your clinicians, am I on the best possible medicine to improve my outcome? Next slide. We also understand that there's another type of new condition that's emerging, non-reduced heart failure, and they slightly differ in terms of the best therapies. And there's emerging evidence for all of these along the spectrum. And once again, ask your clinician, for my type of heart failure, am I on the best guideline-directed medical therapies? And so the next slide will be the closing slide. And I think that, Joel, it was emotional, it was inspiring, it was impactful. And I want to share with you that the reason why I wanted to participate, and thank you, Mark and Shannon, for asking me, is as a primary care clinician, I want to give my patients hope. I want my patients to have hope. And I want my patients to reach out to me. Many patients live well with heart failure for many, many years. Focus on the quality of life. Focus on your family. Focus on those intimate conversations you can begin to have again and the memories you can build. I think it's important as patients, early recognition and intervention by partnering with our patients will change your trajectory, would modify the disease. And remember, your goals and priorities should be shared because they guide every care decision. These disease modifying therapies are the very best in what we have learned from science. They're now available and they're effective. As a patient, you should be asking, am I on the right therapy for my type of condition? And remember, you're not alone. Team-based care workflows work. We talked about the primary care team. We talked about the specialty team. It offers us a safety net so that we don't ever miss patients. When you are a patient, stay engaged. Do something simple like weigh yourself every day, know your action plans, and reach out to your clinicians early. And finally, I hope that my goal and my wish for all of us is that as patients and as clinicians and as healthcare systems and as heart failure, heart function organizations, we all move towards coordinated, integrated chronic cardio-kidney metabolic disease care. And with that, from a family factor to you, thank you so much for your attention and looking forward to your questions and answers.
Daniel, thank you so much. Really appreciate that. And I mean, the way you presented it resonated so well. Knowing that it's a collaborative approach, that it's getting patients on the right therapy at the right time, taking that glass half full approach, right? Contacting your care team if it's, if you're experiencing signs and symptoms, understanding that, particularly across the trajectory of connected conditions, it's a marathon, not a sprint. Really focusing on with your family care provider and team, priorities, goals, barriers, what worries you. And then we're all trying to achieve the same thing, giving patients hope that they could live the quality of life that they deserve. So thank you for that. And next, I have the honor to bring on Morgan. Thank you for coming on. Morgan, we are looking forward to your presentation, From Recognition to Action, Treating Heart Failure and Living Well. Can't wait to hear your perspective. It's all yours.
Thank you, Mark. Thank you so much to the planning committee and group for inviting me to speak today. I'm so grateful to be here with an esteemed panel. To begin, I really appreciated Dr. Nui's comment of following the patient's values as our compass. I think that's very much where I root my practice. And I am also so thankful to share this space, this stage, I guess, with Joel, who reminds me so much of the people that I work with every day and who continue to give me the inspiration to continue to be curious as we join together to tackle this disease. Next slide, please. Heart failure, as I'm sure you've come to know now, is unfortunately far more common than many people do realize. In Canada, over 800,000 people are living with heart failure and more than 130,000 are diagnosed each year. For many, it becomes a part of daily life, as you heard about Joel and his family. For caregivers who participate in supporting people at home with this disease. Heart failure, in fact, touches 1 in 3 Canadians in some way. It's also one of the leading reasons why people come to the hospital, with many people needing to return within the first month after discharge. These numbers reflect far more than just statistics. They do point to the ongoing challenges that people face in managing their symptoms, in navigating the care system, and maintaining a good quality of life. Heart failure matters because it's not just about treating the condition itself, but it's also about supporting people to live well every day. Next slide, please. To simplify how we think about heart failure and how I communicate to clinician learners, as well as patients and families, I often use this analogy of the heart as a house. First, the plumbing. This represents the coronary arteries. Where there are blockages or ischemia, the blood supply to the heart muscle is compromised, and you may visit a plumber or an interventional cardiologist for stenting, or a surgeon for bypass surgery. Secondly, people can suffer from issues with the electrical system. This refers in particular to arrhythmias like atrial fibrillation or flutter. So if the timing of the rhythm is off, the heart can't pump efficiently. For this, you may visit our team members of the electricians or electrophysiologists for things like ablations or pacemakers. Thirdly, the windows and doors. These represent the valves and the overall structure of the heart. If valves are damaged or not functioning properly, blood flow becomes disrupted. I say that these are kind of like the contract workers who you may see either a surgeon or another interventionalist to have the valves replaced. The key point is that regardless of where the problem starts or what it is, whether it's plumbing, electrical, or structural, they ultimately all affect the heart's ability to function as a pump. And if you're suffering from this, you're going to see me, who's like a mechanic, and I work with patients and families to solve the problem with the heart's ability to pump effectively. Next slide, please. As Dr. Daniel just recently went through, we understand that the difficulties of the heart as the body's pump, and that heart failure is a condition where the heart cannot pump effectively to meet the body's needs or requirements for oxygen and nutrients. It is important to recognize that there are different stages of heart failure. As the pump function deteriorates over time, we classify it into stages to help to guide management. Understanding these stages helps to provide us with timely interventions, such as those that Dr. Nui outlined for us, tailored treatments, and as well to support patients at every point in their heart failure journey, and hopefully identifying patients sooner. Next slide, please. At stage A, we refer to people who are at risk of developing heart failure, but importantly, they aren't experiencing symptoms yet. There's no evidence of structural disease within the heart. It's defined that by conditions that raise your risk of developing heart failure. I think Joel listed off a few for us already. Those patients who have risk factors such as high blood pressure, diabetes, obesity, or a family history of cardiovascular disease are higher ranking than others and deserve our higher attention. The focus here is entirely on prevention and our opportunity to intervene early. And I think primary care providers play an essential role here in optimizing blood pressure control, glycemia management, high cholesterol optimization, engaging in weight management interventions, and encouraging physical activity. Heart failure does not start when symptoms appear. It begins years earlier with the underlying structural changes, and those who have intervention early have the greatest opportunity to change outcomes. We encourage our patients to engage with their primary care providers and wellness clinicians to focus on these modifiable factors at this stage. Next slide, please. At stage B is where we start to see things changing. This is early or preclinical heart failure. Patients still don't have symptoms, but now there is objective evidence of cardiac involvement on investigations. There may be structural changes on imaging like echocardiograms. We can see filling pressures or elevated fluid or pressure within the heart, and we start to see biomarker evidence on blood work. The question now becomes, how do we find these patients? This is where screening and early detection really matters. We need to be thinking about targeted use of biomarkers like natriuretic peptides and imaging in high-risk populations. Unfortunately, in many parts of Canada, they still have limited access to this important lab test of NT-proBNP or BNP to identify patients. And there's a huge space for advocacy to increase our access and to enhance health equity. Patients in this stage are if we don't address them quickly, they will continue to progress to stage C, which we'll look at next. Early intervention, again, with primary care or early cardiology involvement, can include initiating important medications such as ACE inhibitors and beta blockers to reduce cardiac strain, as well as continuing to address those modifiable risk factors. The key message for this patient population is that heart failure has unfortunately already started, even if our patients don't feel it yet. If we can detect it early, we have a real opportunity to change the trajectory. Next slide, please. Stage C is where heart failure becomes clinically apparent. People develop symptoms due to the underlying cardiac dysfunction. This can range from mild to severe and include shortness of breath, fatigue, exercise intolerance, fluid retention, and sometimes cough or elevated heart rate. Over the next 2 slides, I'll talk to you about what it looks like and sounds like to me in practice. At this stage, we shift our treatment to symptom management using the guideline-directed medical therapies that Dr. Daniel outlined, along with patient education around fluid balance and sodium restriction. Next slide, please. So when I teach about what does heart failure look like, it doesn't mean just what we see as clinicians or people who are involved in patient care. I also mean what family members and caregivers notice in their loved ones, or maybe also what a person notices in themselves. This includes labored breathing or difficulty breathing, visible swelling in the legs, abdomen, or legs, rapid weight gain, or where your clothes don't fit the same. Families will often describe that the person is more tired, moving slower, needs more time to do the things that they used to be able to do quickly. They have increasing difficulty climbing stairs or doing their usual daily activities. They may notice a change in appetite, increasing frailty, or notice changing in thinking like confusion or poor concentration. Patients themselves or people who care for them notice that they can't lie flat or they're sleeping more upright or have developed a persistent cough. So what it looks like is both clinical observation as well as the person's lived experience. It's what we see and what the people around the patients are noticing day to day. Next slide. Yes. So what does it sound like is what I hear from patients and caregivers. For those clinicians who are attending, patients don't present to us saying, I feel orthopnic or I have PND. So these are phrases that we should be paying attention to because they are non-specific when they present on their own, but as a cluster should raise our attention to heart failure. Patients may say, I'm sleeping in a recliner more often, or I can't lie flat in bed. They may report getting short of breath more easily, not being able to do what they used to do. Something like, I used to take my dogs for a walk around the block every day, and now I can barely make it down the road. Fluid retention can show up in different ways of how they describe their legs feeling heavy, shoes feeling tighter, feeling bloated, or gaining weight, but I'm eating less. They may also describe feeling fatigue, saying, I don't have the energy I used to, and sometimes concentrating on symptoms like waking up at night and gasping for air. Sometimes these are less specific, but just as important are people who come to me and say, I just don't feel right. These patients' reported changes are often the earliest clues, and they're critical for both clinicians and caregivers to recognize. Next slide, please. At stage D, heart failure refers to advanced or end-stage heart failure, when patients continue to have severe symptoms despite medications. At this stage, the question shifts from simply managing heart failure to recognizing when people may benefit from advanced heart failure therapies or specialized care. One helpful mnemonic to identify patients is the mnemonic that's presented here, which is I need help, which highlights key clinical warning signs that heart failure is progressing. Recognizing these warning signs is critical because early referral to an advanced heart failure center can open the door to therapies such as those that Joel had, like LVAD or left ventricular assist device, heart transplantation, or a palliative care approach that focuses more on quality of life. Advanced heart failure is not just about symptoms. It's about identifying a trajectory of disease progression and ensuring that patients are evaluated for the full range of treatment options. Next slide, please. Guideline-directed medical therapy is the foundation of heart failure care, and it is not optional. Over the past 2 decades, there are large clinical trials that have shown that 4 key medication classes do work together to improve symptoms, to reduce hospitalizations, and more importantly, to help people live longer. These are often referred to as the 4 pillars of heart failure therapy, and they are important to be used together, but often clinicians may feel uncomfortable in initiating or titrating the doses and leaving it to specialists who are becoming harder and harder to come by. So some key tricks to starting these medications safely and effectively would be starting low and titrating up. So not starting off with a full whack of dose. These medications do require monitoring, including frequent blood work and reassessment by care providers to ensure that they're doing what they're meant to. Side effects in most cases are manageable as long as we know about them. Each class may have their own unique problems, such as SGLT2s can increase risk of urinary tract infections. Beta blockers may be associated with enhanced fatigue. All play a role in dizziness, but we can, once we know about these, we can work with our patients and their partners to give specific counseling on how to increase tolerances. Delays in starting these medications do reduce their benefits, so starting early and titrating thoughtfully will help to enhance the patient trajectory. Next slide, please. When it comes to titrating these medications, there is no secret sauce. This is taken from a journal from Dr. Sharma and the team at McGill University and presents an excellent algorithmic approach to emphasize a systematic method in titration. And I would refer you to their excellent article here. I also use the QR code quite frequently. This is a link to MedHF, which is a link to the guidelines that help us choose and titrate medications. It's a very helpful clinician resource, and I would encourage you to access it now. Next slide. Many people have questions or worries about talking to me about their medications, and these are some of the things I hear most often. So too many medications. It's true, people with heart failure do take multiple medications, but each one has a purpose, and together they effectively reduce the risk of hospitalization. I often hear too, my blood pressure is too low. Many of the medications we use do reduce or lower blood pressure, and this is expected, and we monitor it closely. Often we can make changes to the doses or timing so that blood pressure is better tolerated, while also we aren't treating a number, we're treating people. So we talk about symptoms that are disruptive versus only the number alone. As we know by Dr. Daniel, there's an intrinsic interlay between the different systems, heart failure, nephrology, and cardiometabolic, and people can pay more attention to one organ than another. Heart failure medicines do affect kidney function or lab values temporarily. This doesn't always mean that the medication is harmful. So it's important for us to take it within the context of the many disease symptoms. Also, finally, patients I hear, I feel okay. Why do I need to start anything? Feeling okay doesn't mean your heart is not under stress. And we can see that through blood work, biomarkers, and investigations. Heart failure can progress silently until it yells at us very loudly. So starting therapy early, even if you're feeling well, can protect your heart and prevent future complications. Next slide. Briefly, just to overview again, and I believe I'll speak to this in the question and answer period, but heart failure care teams are essentially extremely important as they coordinate care across the continuum. There are many people at play here, including primary care and those listed here, as well as we work to create heart-healthy communities, both virtually and where a patient lives. Next slide, please. Our heart failure care teams, as we dive into more treatment, focus on diagnostic workups, education and coaching, medication titration, exacerbation management, where we rely heavily on our community partners like home care nurses and community paramedics. Heart failure teams can also provide specialist home therapies like IV diuretics or IV inotropes, access to palliative care, as well as system navigation. Next slide. Living with heart failure, I would point you to these wonderful resources. I can't order enough of them from my clinic, from the Heart Life Foundation. For those clinicians online, please do access the Heart Life website to access these great resources for patients and families, which places people living with heart failure at the center of their own care. I think information and knowledge is power, and empowerment starts with the confidence in managing day-to-day health. I'll close out with my last slide, which is my 5 cheeky rules for living with heart failure in a heartful way. Sometimes both patients and healthcare providers can take to heart. So first, knowing your numbers, whether you're monitoring your own or supporting someone else, weight, blood pressure, and ejection fraction tell the story of the heart. Medications matter. Take them, review them, and work together to make sure they're optimized. Third, keep moving. Even small daily activities can help the heart and spirit stay strong. Fourth, speak up and ask questions. Open conversations between patients, caregivers, and providers are how care improves. And finally, focus on what matters. Let quality of life, personal goals, and values guide every decision. Follow the rules, and everyone, patients and providers alike, can contribute to a heartful life. Thank you so much.
Morgan, thank you so much for that. Really appreciate that presentation, your perspective. I mean, just, starting from the breakdown of the heart, the plumber, the electrician, windows and the doors, and the general contractors, and you being the mechanic. That's the way you describe the stages of heart failure. A lot of times we get lost in acronyms and jargon, and so appreciate that perspective, knowing that also that GDMT is foundational, not optional. I love that slide on what it actually sounds like, right? I messaged Jenny, our community engagement manager, and said we got to get that on a postcard, and that you're not treating a number, you're treating people, right? And it's important to focus on really what matters, like watching the sunset. So thank you for that, Morgan. Thank you, Daniel. Thank you, Joel, for your amazing presentations. We really appreciate that. And we'll move into the question and answer.
Yes, so go ahead. I know that Daniel's been active in the Q&A, which has been fantastic. We do have one question from the audience as maybe I can present this to Daniel. We see a lot of heart failure patients who struggle with things like affording meds, medications, food insecurity, and even getting to appointments. What can healthcare systems do to better address these social challenges so we can improve heart failure outcomes overall?
Thanks very much for asking that, but I think that this is a perfect explanation about collaboration. So I think organizations like Heart Life Foundation, Heart and Stroke, patient advocates and clinician advocates need to work with governments to reduce cost barriers. We need to address medication coverage. There was a question about special authority. I wasn't advocating necessarily one over the other. I simply said these are options and you need to speak with your clinicians, but we need to work together in collaboration to reduce the cost barriers. We need to also think about the social determinants of health. We need to ensure that food is accessible, transportation, finances. We need to be able to connect our patients to even see our specialists, to have access to an iPad or a computer to do virtual care. So I think the call to action is that we need to work together to address affordability. We need to lobby. We need governments to reduce medication coverage as well as social barriers and funding.
Fantastic. Thank you.
Yeah.
Thank you for that. Question, Morgan, Daniel, where do you see the most recent innovations or opportunities right now in connected conditions? How the health system is looking forward and how it's going to support patients and caregivers?
I can take that. I think that innovative care today is virtual care, one. So I saw someone also pose in the chat box, if someone doesn't have a primary care provider, what are the options? I think that there's different opportunities and that are coming out and registering. And I know that there's huge my goodness, advances in connecting every patient with a primary care provider. So number one, I think that's basic and foundation. That's not innovative. That's something we should have been doing a long time ago. Virtual care and increasing access to those to specialist cares, whether it's by video, remote home monitoring is another big piece. But in that interconnectedness, at the HF update, there was a great presentation on combined visits with specialists between a cardiologist or cardiology team, nephrology, and endocrinology. And I think that moving towards more efficient visits, even if they're a bit longer, having people at the same table to make those decisions immediately so that it reduces the delay to good optimization in our care medications. So that's what I'm looking forward to.
I'm so looking forward to Joel speaking, actually, but I'll quickly give my answer. Before we thought about diseases in silos, today we need to start thinking about diseases that are interconnected. And one last interesting tidbit is I just gave a talk in Toronto on agentic artificial intelligence in healthcare and how we can use AI to identify patients with maybe an early cardio condition or an early metabolic condition or early kidney condition and start asking patients, hey, I'd like to speak to you. Let's have a group visit. Let's have a one-on-one so we can early address the CKM syndrome to prevent heart failure. So I'm really looking forward to that and to Joel.
To me,
Thank you,
I am
Daniel. Thank you, Morgan.
the original example, I guess, of this. But yeah, I just wish I would have paid attention. To what the
Joel,
doc.
there's a question for you, Joel,
Yeah.
if I may. If you can remember or think about a moment in your health journey, sometime in the system, whether it was with your physician or a nursing partner, an instance that really made a positive difference in your care, what that was and why.
A positive difference in my care. I think, honestly, a positive difference in my care is when I got scared and I had pneumonia and I thought I was going to die, and they were telling me I needed a heart transplant because I finally listened to what the doctors were telling me and to what my body was telling me. I needed to be afraid because I spent my whole life not being afraid of anything. If somebody said jump off a bridge, I would probably be the first one to do it just to see what happens when I land at the bottom. So realizing that I was mortal and no matter what I did, I couldn't heal anymore. That was probably the negative and positive moments in my life where I'm like, okay, I'm not okay. I need help, and it's okay to get help.
Thank you for sharing that.
If I may add to that, I think that it's an excellent time to bring up too for Heart Failure Awareness Week that mental health matters in people suffering and dealing with cardiovascular disease every day, as well as their caregivers. And I think that we can pay attention. We have so many interventions for the heart. We just went through, the Fantastic Four and tech care and all of this, but really, how do you mentally wrap your mind around what's going on? Where do you get help? Where do we accept that it's not just about this one organ, that it's about the whole person, and beyond that to the family and caregivers, and that I would love to see more access to supports for mental health. And I think that Heart Life does a great job for that, and the support communities for women in heart disease. Yeah.
Thank you for that, Morgan. Appreciate that.
Yes, thank you so much. Thank you for this thoughtful discussion today. Before we close, we do want to take a few minutes just to walk through what happens next after the webinar. Recording will actually be shared today for today's session and will be made available and shared on the Heart and Stroke and the Heart Life's website. And you'll also find links to the chat so you can visit and revisit and share the webinar with colleagues, patients, and caregivers. And we also invite you to complete the brief webinar evaluation, as your feedback helps guide future webinars. And once completed, you'll receive a certificate of participation. And before we close, we've shared the Heart and Stroke resources that you can use and also share. And you can visit the Heart and Stroke or Heart Failure and scan the QR code for additional resources and supports, in addition to the Heart and Stroke Community of Survivors and Community of Support for Peer Connection. And we also encourage you to visit the Canadian Heart Failure Society, the heartfailure.ca, for additional resources and clinical resources. And all links will be also in the chat. And then lastly, we do want to highlight excellent resources from the Heart Life Foundation. And you can explore heartlife.com for patient-centered education and support, including heart failure and caregiver for caregivers. And also for learning and professional education, visit Heart Life Academy. and any for also system level work and policy context, the Heart Life Hub and the framework. And all Heart Life links will be in the chat as well. So we encourage you to explore and also to share these resources widely. As we begin to close today's webinar, I do want to take a moment to thank everyone for joining us today. And on behalf of Heart and Stroke Foundation, as well as Heart Life Foundation, thank you to our presenters for your meaningful contributions today. Bridging heart failure care really depends on voices like yours, and your contributions today play an important role in advancing heart failure awareness and helping people across Canada recognize symptoms sooner, seek care early, and feel supported in living well with this condition. And with that, I want to thank everyone for joining us today, and we wish you a wonderful day. Thanks, everyone.
Thanks,
Take care.
everyone. Take care. Bye, everyone. Have a
Bye-bye.
great day.